This, without delay, I hand over the session to you. Thank you.
Thank you very much, Puneet. And once again, I welcome all of you for this masterclass. Today, we have got another set of experts who have been masters in their field. The examiner today is Dr. Sreejith, who is a HOD nephrology at JIPMAR. Another brilliant nephrologist, very aggressive, who is again a very learned person and good teacher. So he will be examining his student, Dr. Sainath. And to discuss the case, we have got another bright nephrologist, famous nephrologist, respected nephrologist, Dr. Edwin Fernando, who is professor and head at the Government Stanley Madras Medical College. The expert for today is once again Professor Kasi Visweswaran, again a very, very respected and very senior academician and clinician who has got a special interest for tropical nephrology. Before going to the topic, I request Professor Kher to please introduce the topic and we can move ahead after that.
Thank you. Thank you, General Verma. It's a pleasure to be back again with another session of Masterclass in Nephrology. And as General Verma said, the topic today is crescentic nephritis. And crescentic nephritis has always been of great interest to nephrologists. And not only that, it is a very important acute condition which needs to be diagnosed very, very early. And the only way you can diagnose this would be by a kidney biopsy. And many times patients are sick enough, so one might have to dialyze these patients before they get good enough for a kidney biopsy. So the kidney biopsy, doing it as early as possible, because if you make a diagnosis early enough, then one might be able to intervene with aggressive immunosuppressive therapy in these conditions by and large. And to discuss this topic, I think Sreejith is going to start, and then Ms. Kedhara. I think Kedhara is going to present the case. She's a third-year resident, and I think we will ask her to go ahead. Sreejith, we are okay to start straight away?
Sure, sir. I'll share the slides so that the case details
sure.
are. So we have the slides up here, and the resident's name is Dr. Gowri. Her name is Kedhara Gowri Sainath, so we can call her Gowri to be easier. So Gowri, can we start with the case?
Yes, sir. Good evening to everyone. So I'll start with the case presentation. The personal details of the patient. He's a 64-year-old male from Dharmaburi, Tamil Nadu. He's not formally educated, and he's a cow herd by occupation. I'd like to begin with the background history. So he was apparently normal till May 2025 when he presented with complaints of fever and cough. The initial complaint was fever, which was low grade. It was present daily. Intermittent episodes of fever were present more in the evening. This lasted for around 20 days, and this was associated with generalized body aches. There was no associated chills, rigor, joint pain, sore throat, or any skin rashes. And a patient took paracetamol tablets for the same from local center. There was a patient noticed cough. This was noticed after 2 to 3 days of onset of fever. The cough was of insidious onset, and it was predominantly dry. And occasionally there was associated scanty white sputum. There was no history of any hemoptysis, shortness of breath, or chest pain. And 2 weeks after the onset of these symptoms, he started to notice swelling of both legs up to the ankles, which was painless, and this was associated with facial puffiness. There was no history of any hematuria, frothing of urine, reduced urine output, abdominal distension, or any history of nocturia. Along with these symptoms, he also developed a history of loss of appetite, nausea, and vomiting episodes, around 6 to 8 episodes per day, which were non-bilious vomiting associated with loss of weight. History of around 4 to 5 kg weight loss over the 20-day duration. There was no history of any epistaxis, redness of eyes, headache, blurring of vision, or seizures. So with these complaints, he presented to a hospital in his hometown. So he presented 20 days after the onset of symptoms, and he was told to have severe anemia and kidney failure in the hospital. And he was started on hemodialysis via a catheter in the right side of the neck, and he received 2 units of blood transfusion. Following which he underwent a kidney biopsy from the right side, and it was uneventful. Following that, there is history of receiving IV medications daily for 3 days. Following that, he was continued on treatment with oral medications. After the biopsy report was available, the patient was informed that he had a severe irreversible kidney damage in the biopsy, and he was informed that the treatment for cure of kidney disease was futile, and his prescription was changed accordingly. And subsequently, he was discharged after 10 days of admission, and he was advised AV fistula creation, and he underwent AV fistula creation in the left fora. After 1 month of creation of AV fistula, the neck catheter was removed and he was dialyzed via the AV fistula subsequently. So he continued to be on hemodialysis twice weekly. His urine output was around 500 to 750 ml per day, and he had an interdialytic weight gain of around 1 to 2 kgs. He received 2 doses of hepatitis B vaccine and iron injections and EPO injections once a week. With this, his appetite improved and he became symptomatically better.
Yeah, so with this history, what do you think? What are possibilities would you like to consider, Dr. Gowri?
So he's a 64-year-old male with he has no known comorbidities, and he presented with 20 days total duration of his history of symptom duration of 20 days. The symptoms were predominantly initially began with fever, which was low grade with predominantly dry
Sorry,
cough.
so basically, to cut it short, you basically have an elderly person with no non-premorbid illness. He was apparently well. Then he developed a loss of appetite, nausea, vomiting, edema, and then weight loss. He had symptoms which looks like respiratory infection. He was found to have severe anemia requiring transfusion, and he had kidney failure requiring dialysis treatment, and he underwent a kidney biopsy. So the kidney size is probably normal. And this total duration of illness is around 3 to 4 weeks. So this is, I think, a summary of this case. So when that is the situation, what all possibilities would you like to consider?
First possibility, syndromic diagnosis will be RPRF, rapidly progressive renal failure. Second will be.
Can you tell what is the reason? What is RPRF and why do you consider in this patient?
So RPRF is renal failure or doubling of creatinine occurring over a period of weeks, more than 2 weeks, and more than 1 week and less than 3 months. In this
So
patient
rapid
had
progression is usually when there is worsening of
Rapid.
worsening of renal function, and the duration is less than 3 months. Right, it's usually few weeks to less than
3 months.
3 months. All right. So okay. All right.
This patient is a 64-year-old male and elderly male with no known comorbidities.
Yeah. So one possibility you are telling is RPRF. Anything
Yes,
else other than RPRF you would like to consider as a possibility?
Yes, sir. Acute on CKD will be second possibility. Underlying
Okay.
CKD.
All right. So why do you think the patient might have been having CKD, and why do you think patient developed AKI?
Sir, AKI might be due to the fever and respiratory symptoms he had. He might have had a viral or some respiratory illness, viral illness, which precipitated, for which he had also taken some, he had body ache and he had received some tablets. So there might be NSAID use and there can be
All right.
NSAID
So what
related
about
AKI.
CKD? You were telling he was asymptomatic before 4 weeks.
Yes, sir. Still, a patient had presented with severe anemia and dialysis, renal failure severe enough to require dialysis, and it and after biopsy he was told that further treatment, he had
No, but
irreversible
how
damage
do
in
you
the kidney.
explain? His symptoms are only for 3 to 4 weeks, right? So
Yes, sir.
there may be an AKI, but underlying CKD, what is there to say that the patient might have had CKD?
The presence of anemia, and
Okay.
presence of severe anemia at presentation.
Any other reason that he is asymptomatic? No, can it be CKD be asymptomatic?
Um, Yes, sir. Many patients can, many of the CTID patients can present at advanced stages when
All
they are
right.
having
All
severe
right.
anemia.
So I think the point you are trying to make is that this person seems to have come from an area where we know that CKDU is endemic, and we know that most of them are asymptomatic and they are detected only when they are tested. Okay, and this patient is so. All right. So we are telling one first possibility is according to you is RPRF. And what do you think could be the cause of RPRF based on the available information?
So he's a elderly male, anemia and renal failures also. First possibility will be multiple myeloma. Multiple
Okay,
myeloma with cast nephropathy can be a possibility. Then he had he had anemia with chronic cough and renal failure. So if we possibility of underlying vasculitis, RPGN with underlying vasculitis, might be ANCA-associated vasculitis is another possibility, sir.
Okay, other than renal failure, respiratory symptom, any other reason to suspect he may have had ANCA-associated vasculitis?
Sir, he had constitutional symptoms like fever, loss of appetite.
And weight loss, right? You actually mentioned 4 to 5 kilo weight loss. So
Yes, sir.
elderly man, fever, weight loss, and then he comes with renal failure, right? Okay, all right. Any other differential diagnosis? This patient, elderly man, has come with rapidly progressive renal failure and severe anemia. One possibility you are telling is ANCA-associated vasculitis. One is cast nephropathy related to myeloma. Any other possibility you would like to consider?
Yes, sir. Anti-GBM disease.
Okay.
Considering the age, anemia, and renal failure.
All right. Okay. All right. Anything else?
Uh,
What are the conditions where you see where you have RPGN with significant anemia? Not only I'm telling generally I'm asking. RPGN, significant anemia.
that it can be present in hemolysis, like SLE with autoimmune hemolytic anemia.
Okay. All right.
Or it can be present in SLE again with TME, APLA mediated
Okay.
hemolytic
Thrombotic
micro.
microangiopathy may
Yes,
not be
sir.
SLE. It can be SLE or thrombotic microangiopathy can have anemia. All right. So RPGN, one is hemolysis from autoimmune mechanisms or microangiopathy hemolytic anemia. Any other reason why RPGN can have anemia? Significant?
So DAH, the blood
Oh,
loss in
all
the
right.
lung.
Epicellular hemorrhage. So summarizing, so what is your, at this point, what are the clinical possibilities you are considering?
That first possibility, syndromic diagnosis, two possibilities. First is RPRF, and second is acute on CKD. And in RPRF, I'll be considering myeloma with cast nephropathy as first possibility. And second, ANCA-associated vasculitis, RPGN with ANCA-associated vasculitis, and third, anti-GBM disease.
Okay, all right, fine. So let us go ahead with the rest of the case details quickly.
Will you call 54-year-old man elderly?
64, sir. 64.
Yeah, 54 you said.
64, sir.
Year old means.
It's 64.
Chowsat, yeah.
Okay.
64, sir.
Okay. So then senior citizen. All right. Now you are
That
justified.
is,
You are justified.
General Verma, that is government definition also.
I know, that's why. I heard 54. So
No,
that
sir,
is why
sorry.
I asked.
Okay.
History of presenting illness.
Yeah.
In August 2025, he presented with 2 weeks history of shortness of breath, which was insidious onset, and it predominantly in the night. He used to wake up
So
at
this,
around 1
can you
a.m.
just for clarity, this was how long after the initial illness and starting dialysis, Gowri?
Sir, in June he was initiated on dialysis. In June was the first presentation was in June, and 3 months later, around 2.5 months later,
All
he
right. Okay.
presented in
Go ahead.
August. Yes, sir. He presented in August with the complaints of shortness of breath for 2 weeks, which was predominantly like PND, waking up at around 1 a.m. in the night. And there was history of associated mild swelling of legs and excessive fatigue. And he reported improvement in symptoms post-dialysis with worsening on the day before hemodialysis. Um, After 1 week later, he started to develop a cough with blood in sputum, which later became frank blood in sputum. The volume of blood was less than 50 ml per day, and this hemoptysis was present throughout the day. There was no postural or diurnal variation, and there was no associated fever, sore throat, chest pain, or any decrease in residual urine output. There was no history of any pink frothy sputum noticed by the patient. With these chief complaints, he presented to JIPMER on 5th September 2025, and blood and urine investigations were done and underwent a CT scan. Following that, he was started on IV injections daily for 3 days, followed by oral medications, nebulization, and he was started on plasma therapy along with dialysis, which he received on alternate days. He received 2 units of blood transfusion and 5 plex sessions. Following that, patient noticed improvement in symptoms and his hemoptysis gradually resolved. And there was also history of use of insulin injections for increased blood sugars in hospital.
Yeah. So with this additional information, what do you think was happening to this patient? He had a renal failure, underwent biopsy, was declared CKD, was on dialysis. He was on dialysis for 2 months, and then he has come with another set of symptoms. How do you explain this?
Hemoptysis. Currently, patient is admitted with hemoptysis following 2 months after a dialysis requiring renal failure, which was deemed to be not amenable to treatment. So, first possibility, currently, so DH with RPRF. So, I'll be thinking of anti-GBM disease as the first possibility.
What is the reason? Do you think it is anti-GBM disease?
Um, Considering the age, 64 years, and second, it was a short duration of illness in the first place, 20 days duration, and following that biopsy was done, and he was told to have severe changes in the kidney, and he was not given any immunosuppression or plasma therapy at that point, and subsequently now he has presented with DAH. So first possibility will be anti-GBM disease, but ANCA-associated vasculitis is also a close second possibility, sir.
What reason
Gowri,
you are
could it be a patient with pulmonary edema and fluid overload in a patient of dialysis, usually getting twice a week dialysis? Sometimes they may, I don't know how frequent he was getting, but could it be fluid overload and pulmonary edema?
Yes, sir. That is also a possibility that the fluid overload was present, which precipitated the DAH. Because he even though he had improvement in symptom post dialysis, the imaging after dialysis still showed persistent infiltrates, and he had persistent symptoms as well. Hemoptysis was persistent.
Okay.
With significant HB drop.
Diffuse alveolar hemorrhage was your clinical diagnosis?
Sir, initially when he presented pulmonary,
He told you that logically you think common things common first.
yes, sir.
The person is presenting with hemoptysis. Possibly you will always entertain a possibility of pulmonary edema. or some chest infection he is having. He may be having a pneumonitis. Or you
Yes,
will
sir.
go to diffuse alveolar hemorrhage as first diagnosis.
The first possibility will be pulmonary edema, sir. Considering that he had pedal edema and PND symptoms and some improvement post dialysis was also reported by the patient. So we initially took up for intensive dialysis, but even after dialysis, the symptoms persisted and there was further dropping hemoglobins. So the first possibility will be pulmonary edema.
So
Yeah, you can go ahead. Sreejith, go ahead.
Yeah, so you are saying this patient probably had fluid overload, and then initially there was some symptomatic relief, but then it seems to have been complicated by some additional problem because patient has persistent hemolysis and the symptoms were not getting relieved despite ultrafiltration. So you are suspecting diffuse alveolar hemorrhage. So can you tell us, in a patient with suspected diffuse alveolar hemorrhage, how will you like to confirm it, or what investigation, or what would you like to do? Because that is a significant complication, right?
Yes, sir. Uh, Sir, in a patient with dropping hemoglobin, first we will be doing chest X-ray imaging, like chest X-ray and HRCT. Following that, for confirmation, DLCO has very high sensitivity. DLCO
What
can be
is DLCO?
sir, diffusion capacity of carbon monoxide.
Okay, all right. And how does it help?
Sir, it is increased in DAH. There will be increased
So,
uptake of carbon
would,
monoxide.
can you tell me what in this patient would you have like to do DLCO?
Uh, yes, sir.
What is
Uh,
the challenge? Usually, what is the problem in doing DLCO in a patient with diffuse alveolar hemorrhage?
So it can be done in clinically stable patients, in critically ill patients or patients who are requiring
So
oxygen.
if
It is
the diffuse
difficult to
alveolar
perform.
hemorrhage is significant, that is when it is its sensitivity is high because it will be very high DLCO because the blood is in the lung interstitium. The carbon monoxide uptake will be very high. But then it is positive when there is significant bleed, and when patient is having significant alveolar hemorrhage, they usually can't hold their breath. So there is a
Mm,
practical challenge in doing that, right? But if you are
mm.
able to do it, yes, it is a supportive thing. Okay, what else? What else other than DLCO? We don't have DLCO, so we can't do it, right? So what else?
So bronchoalveolar lavage, and we look for hemosiderin-laden macrophages, sir.
Okay, very good. All right. Anything else? What did you do for this patient?
Sir, based on the clinical, he had a worsening, like dropping hemoglobin, and there was frank hemoptysis, and HRCT chest was done to rule out
All right. So
infection.
CT chest will help in some way.
Sir,
What
we
will you find in
can.
CT chest?
There can be ground glassing and there can be consolidation as well, sir. And there
All
can
right.
be some peripheral sparring.
Okay. All right. So you have
Can
a
hemoglobin-laden
patient here.
macrophages help in the sputum?
Sir, can you repeat the question, please, sir?
Can hemoglobin-laden macrophages in the sputum help?
Yes, sir. We can do bronchoalveolar lavage, bronchoscopy lavage, and hemosiderin-laden macrophages can be, um, it can be diagnostic of DAH, sir.
But what sir is asking is whether we can
Sputum.
look for it in the sputum.
So usually ball fluid is what is usually used, sir.
I
Sputum.
suppose if you, I'm not absolutely sure, sir, but if you're able to find hemosiderin-laden
We are able to find
macrophages,
hemosiderin-laden macrophages, it indicates alveolar hemorrhage.
yeah.
So in
So if you're
BAL,
able
it's a
to
very
find it,
invasive
yes.
procedure. So if
Yes, sir.
you can look for hemosiderin-laden macrophages in the sputum, if any.
Yes, sir.
Yes, sir. Thank you, sir. Thank you, sir. So, moving on, Gowri. What is this pulmonary renal syndrome? And can you tell us what is the difference between pulmonary renal syndrome, Goodpasture syndrome, and Goodpasture's disease? Are they all the same or are they different?
Sir, the difference, pulmonary renal syndrome is any clinical condition where both lung and kidneys are affected. So it can be ARDS, sepsis ARDS AKI, or kidney failure with pulmonary edema, or pneumonia with AKI, any condition where both are involved. Whereas good pasture syndrome will be DAH with RPGN. And good pasture disease is DAH, RPGN with anti-GBM antibody positivity, sir.
Yeah, so the difference is that we will call it good pasture syndrome when it is a specific pathology. In the lung, it is diffuse alveolar hemorrhage, and in the kidney, it is RPGN, right? And when this is due to anti-GBM antibody directed towards the GBM antigens, then you will call it good pasture disease. So can you tell us what are the common causes for good pasture syndrome? DAH with RPGN. What you
Yes, sir.
usually see in clinical practice?
So ANCA-associated vasculitis is ANCA-associated vasculitis,
Okay.
SLE with DAH,
All right.
IgA nephropathy presenting with DAH, so IgA nephropathy, henoch-Schönlein purpura.
All right. Yeah,
Or
okay.
in
I'm not sure for the information of the audience. The IgA vasculitis, I am not how well recognized it is, but we have at least 2 papers from JIPMER published from the medicine department of diffuse alveolar hemorrhage, pulmonary hemorrhage in patients with IgA nephropathy. So it seems to be under-recognized. That is why she is selling IgA nephropathy. We discuss in the department, but then you may not find it commonly in literature, Gowri. So immunological conditions like ANCA-associated vasculitis, lupus, agreed. Anti-GBM disease per se, all right. What else? What are other
yes,
conditions where you can have pulmonary renal syndrome? May not be RPGN, but other conditions producing pulmonary renal syndromes.
so
Any
drug-induced
infections,
vasculitis.
drugs?
Drugs can cause
Which
use
all
of
drugs?
propylthiouracil,
Infection?
minocycline,
All right, very good. Infection?
cocaine can cause.
All right, very good. Okay, drugs. What about infections?
The pneumonia with
Any
AKI.
specific infection? Pneumonia, all right, but influenza is well known, right? What other infection can produce alveolar hemorrhage? Any tropical infection you are aware of, where you can have pulmonary renal syndrome with diffuse alveolar hemorrhage? Used to be very common, leptospirosis, right? Okay. In fact, there is a syndrome, pulmonary renal and hepatorenal sort of presentations can be there. Alveolar hemorrhage was common with the leptospirosis. So again,
You also have it in hantavirus infection. Sreejith?
yes, sir.
You also have it in hantavirus.
Yes, sir.
Yeah.
First diagnosis for leptospirosis.
Hantavirus, yeah.
Correct. Yeah. So, pulmonary renal syndrome and then good pasture syndrome is different, and then good pasture disease. All right. So, let us go ahead with the case, Gowri.
Past history, he's not a known case of hypertension, diabetes, pulmonary TB, or bronchial asthma in the past. However, there is history of allergic rhinitis for around 30 years. On and off use of cetirizine tablets is history is there. And personal history, he's a mixed diet consumer with normal bowel habits, no history of consumption of alcohol, tobacco, or any smoking history. Family history, there is no similar illness in the family.
I think you need to include also exposure to hydrocarbons. If you are talking about good pasture syndrome,
Anti-GBM.
you need to talk about hydrocarbon exposure.
Yes, sir. So I'll summarize the history, sir. He's a 64-year-old male with no known pre-morbid illness, symptomatic from May with low-grade fever and dry cough for 20 days, pedal edema and uremic symptoms for 1 week, and initiated on dialysis, received 2 blood transfusions and underwent a kidney biopsy. Received 3 days of IV injections followed by oral medications, probably steroids. Subsequently, he was on regular dialysis via left radiocephalic fistula, and he was managed at end-stage renal disease. presented 2.5 months later with worsening breathlessness and hemoptysis, following which he received 3 days of IV injections and alternate day plasma exchanges with dialysis and blood transfusion, following which he had symptomatic improvement.
Yeah, so considering all the information so far, what will be your differential diagnosis? What is the first possibility you would like to consider? Second possibility?
First possibility will be anti-GBM disease. Second possibility, ANCA-associated vasculitis.
Okay.
How common it is, suppose the possibility one you were saying, how common it will be to have pulmonary symptoms after the kidney disease has died down or after 3 months?
Patients can have delayed hemoptysis, but it is seen in around less than 10% of patients. And usually there will be some trigger before the pulmonary hemorrhage, like some lung infection or smoking or volume overload precipitating pulmonary hemorrhage.
Okay.
And any significance, what sort of treatment was he given for the first episode? Was anti-GBM tested, Gowri, and what sort of treatment was given?
So in the initial presentation with the dialysis requiring inferior elsewhere, sir, and anti-GBM was not tested, and kidney biopsy was done, and he received IV pulse steroid for 3 days, and he received 1 dose of IV cyclophosphamide as well outside, sir.
Yeah.
But
So,
history-wise, he's not aware.
yeah, so one possibility, because it was dialysis dependent, immunosuppression was stopped and anti-GBM was not checked. So it is possible if it was anti-GBM disease that he had persistent antibodies, then it becomes a risk factor for other complications like pulmonary hemorrhage, right? So that is one significant history, because he was not tested for any of this, be it anti-GBM or ANCA at that point of time. The only investigation, primarily because of financial reasons, I believe, we have also not done some of the investigations, but yeah, then when subsequently when somebody has circulating anti-GBM antibodies and then there is a trigger, be it volume overload, be it respiratory infection, be it some other sort of exposure, they can precipitate anti-GBM disease, but that is not the usual presentation, right? Okay. So how would now you are saying this patient had RPGN and now has diffuse alveolar hemorrhage. He seems to have responded to treatment, immunosuppression and pulmonary plasma exchange. And you are considering the possibility, one, anti-GBM disease, two, ANCA-associated vasculitis, followed by other possibilities. So how would you like to investigate this patient?
Begin with the basic investigations like CBC, peripheral blood smear, and look for the cause of anemia.
How would you like to confirm the diagnosis? What investigation would you like to do?
The serological investigations, anti-GBM antibody, then ANCA titers, ELISA, we'll check the MPO
What
PRT.
tests will you specifically ask for, Gowri? That's my question. What all tests will you specifically ask for? Can you give a list of tests?
The C3, C4, ANA, ANA by immunofluorescence, and ANCA by ELISA, and anti-GBM by ELISA, sir.
Okay, all right. So you are saying ANA and C3, C4 when your differential diagnosis is anti-GBM and ANCA. So what is the reason? How common is ANA if somebody is having anti-GBM disease? Is that a commonly recognized form of dual disease?
Usually ANCA and
All right.
anti-GBM are associated.
Okay, so can you tell us something about dual disease? How common is anti-GBM antibody with ANCA? How common is anti-GBM antibody with ANA? How common is ANCA with ANA? And what is the significance?
The dual positive
First
and
anti-GBM. Suppose you have people with anti-GBM, in what proportion of them you will find ANCA?
so around 1/3 of anti-GBM patients can have coexisting MPO ANCA.
Very good.
And
So what is the significance of that? If you find ANCA, and which ANCA are you likely to find?
MPO, sir.
Okay.
MPO
And
ANCA.
what is the significance of that?
So the usually the clinical significance will be we need to continue immunosuppression beyond 3 months. We will be giving a maintenance phase with azathioprine as well in view of coexisting ANCA positivity.
Can we go ahead with your investigation so that we can have clear picture what it is?
Yeah, sure. Let's go ahead with the investigations, Gowri.
Sreejith, 2 points I just wanted to raise. One is considering the prevalence of tuberculosis in CKD and the fact that we did consider a CKDU baseline in this patient. Hemoptysis should alert a possibility of tuberculosis also. Quite common because this patient had loss of weight. He had, vomiting and then hemoptysis. Of course, there's a different scenario here. The second thing, when you started off the investigations as a nephrologist, I would have expected you to say the urine routine first, because your diagnosis here is based on the urine first before going to serology. So what I think that is something that is missed. So you must begin with the urine.
Yes.
He had urine when he came in, isn't it?
Yes,
He was
sir.
not anuric.
Yeah,
No.
he said 500 ml per day.
Yeah,
Yeah,
can you
please
quickly-
carry on.
Go
Please
ahead,
carry
go ahead.
Can you quickly go through the
Uh,
physical examination findings, Gowri?
Yes, sir. General examination, conscious cooperative, vitals, pulse rate was 102 per minute, regular, normal volume character, and all peripheral pulses were palpable. Blood pressure was 148/76 in right arm in sitting position, and respiratory rate was 20 per minute, and he had 90 Fahrenheit temperature with a BMI of 20.7.
Any positive findings in the rest of the physical examination?
Sir, he had pallor on general physical examination, pallor. There was no pedal edema, and he had a left radiocephalic fistula. And nails, there was pale horizontal bands were seen. Otherwise, the eyes and ENT examination was normal, and respiratory examination, there was bilateral infraaxillary and infrascapular area inspiratory crepitations were heard. The rest of the examination was with the normal levels.
All right. So
Serious abdomen.
can you tell us about
Investigations. Yes, sir. The initial June when he had presented, he had severe anemia. This was the first report available with HB of 6.3 with normal platelets, and his creatinine at presentation was 9.2. So currently, he was admitted on 5th September here, and at presentation his HB was 6.5, and he had thrombocytopenia as well, 83,000 platelets, and his albumin was 2.9. Subsequently, he was dialyzed, and he had worsening of HB in hospital from 6.5 to 5.5 despite transfusion. And later, further transfusions were given, and there was plasmapheresis also was given. Subsequently, he had improvement in HB. It was static at around 8.
You want to go to the next slide?
Yes, sir. The urine analysis, the initial urine analysis in June, 2 plus proteinuria with 12 to 15 RBCs were there, and urine PCR was 2.9. And current admission, 3, he still has preserved urine output, so 3 plus proteinuria with field full of RBCs and occasional WBCs, and urine PCR of 7.5. Serology, serum anti-GBM antibody by enzyme immunoassay was done, which at admission it was 54 units per ml, and after 5 sessions of plasmapheresis, repeat was normal, less than 7 was normal, and other viral markers were negative. Imaging, this was the initial imaging in June. So he had normal size kidneys at presentation in June, 9.5 and 10.2 centimeters with Caltert CMD. And HRCT chest was also done in June, which was showing mild peripheral subpleural fibrosis and atelectatic changes in both the lungs. This is the on the right is the current X-ray at admission compared to the previous X-ray in June. So there was a bilateral diffuse interstitial infiltrates. And kidney biopsy done on 18th June 2025. So this is the kidney biopsy report, sir. Light microscopy, 36 glomeruli were present, 2 globally sclerosed, and the remaining 34 glomeruli, there was global cellular crescents and normocellular capillary loops and mesangium. There was multifocal RBC cast and nil IFTA, and interstitium was showing diffuse plasma cells and lymphomononuclear infiltrates with normal arteries. And IF 18 glomeruli were there. There was diffuse linear global IgG positivity, IgG, kappa, and lambda 3+, along the glomerular capillary loops, and C3 2+. IgM and IgA were negative. Suggestive of crescentic gene.
Yeah, Gowri, if this was an ANCA associated vasculitis, what would have been the histological findings? Would it have been any different if it was crescentic GN there as well? So how would you say, even without the availability of a diffuse linear global positivity on immunofluorescence, if you were to look at light microscopy, is there anything in the biopsy which suggests that this is likely to be vasculitis and this is likely to be anti-GBM disease? So what is different in ANCA-associated vasculitis on histology?
Yes, sir. So in light microscopy, in anti-GBM, the pathology, the crescents are usually global, like almost all of the glomeruli will be involved, and the crescents all will be of same age, which was the scenario here. And yes, sir. And the capillary loops were also normocellular. There was not much of endocapillary proliferation or inflammation in the capillaries. So all of this is pointing towards anti-GBM disease. Whereas in ANCA-associated, we will be expecting crescents of different age. There can be associated IFTA, and there can be fibrinoid necrosis also, sir, in the vessels, and also inflammation and endocapillary proliferation also can be present, and the disease can be focal.
Okay.
Good.
Yes, good.
In this situation,
you can go ahead.
1 minute. In this situation, if you have global cellular crescents and normocellular capillary loops, is it better, or the prognosis is better with endocapillary proliferation and cellular crescent?
Sir, if endocapillary proliferation is there, then there might be a coexisting pathology along with anti-GBM, like maybe ANCA with anti-GBM.
No, what sir's question is, the prognosis is better or worse?
Prognosis might be better if there is underlying
endocapillary proliferation.
Yes.
That's what I meant.
Yeah.
Okay,
Right, so,
go ahead.
Yeah, let us finish quickly in next couple of slides, Gowri. What was the CT showing?
So there is mosaicing is there, mosaic pattern, and there is ground glassing and some areas of consolidation as well.
So what is your final diagnosis?
He's a case of chronic kidney disease, stage 5D, basic disease, anti-GBM disease with diffuse alveolar hemorrhage, status post plasma exchange, severe anemia of blood loss, and chronic disease with systemic hypertension, steroid-induced hyperglycemia, and chronic allergic rhinitis.
So this patient initially was found to have crescentic GN, and a decision was taken not to give immunosuppression. So can you explain that? Would you have done the same thing, or you would have done anything different?
The patient had 100% cellular crescents in biopsy, and he also had dialysis requiring renal failure. At presentation itself, he had the probability of him recovering renal recovery with immunosuppression is very less than 5%. So considering his age and the clinical picture, better not to proceed with immunosuppression and treat a CSR.
Yeah, so when you look at the risk-benefit angle of it, this is anti-GBM disease. It was not done, but from histologically it was evident. and he was dialysis dependent, and he was 64, and his BMI was 20, right? So he is not a good candidate for immunosuppression, especially when you know that the chances of recovery is very, very low, right? So that decision was right. Probably any of us also would have done the same thing. But then this patient had pulmonary hemorrhage, documented on CT scan, drop in hemoglobin. So when you have somebody with anti-GBM disease, pulmonary hemorrhage, how would you go about treating that patient?
But first, we will initiate on plasma exchange as early as possible, sir. Along with blood transfusions, we will stabilize the patient, airway management, then hemoglobin, like PRBC transfusions, and then initiate plasmapheresis as early as possible. Along with that, steroid pulse and
Can you tell us
cyclophosphamide.
something about the plasma exchange prescription you would use in this patient? He has anti-GBM positive, crescentic gene, he has alveolar hemorrhage. What will be your prescription for plasma exchange?
That we will be giving 1 to 1.5 times the estimated plasma volume, and
What is
preferably
recommended?
daily.
Is it 1.5 or?
KDIGO recommendation is 40 to 50 ml per kg of body weight.
That is 1.5 times.
Yeah,
Yes,
so
sir.
it is 1.5 to 2 times. It's larger than the normal plasma exchange. And how frequently will you do it? And how many exchanges will you do?
So daily exchanges preferably needs to be done. So,
And how many?
till the anti-GBM titers become negative.
Okay.
Gowri, 2 questions to you before you finish. One, this is anti-GBM disease, and you know that antigen is there in the alveoli. Will you give immunosuppression, and how much, if at all? Number 2, patient says, now I am all right, I want to undergo transplantation. Your comment.
Sir, for the second question, currently he is having circulating anti-GBM antibody, and he presented with diffuse alveolar hemorrhage. So till the titers are negative for at least 6 months, we will defer kidney transplantation.
Good. That is one. That is question 2. That's all right. That you monitor the titers, and 6 months there should be no titer, and then only you think about transplant. If you do the transplant, is there a chance of recurrence, you mean?
So it is very rare, sir. Usually there is
How common is the recurrence in anti-GBM disease?
then 5%.
Less than 5, 3% or so. Second, about the disease, immunosuppression. You have treated him with plasma exchange. You have tried to reduce the antibody levels. You have been successful in reducing the antibody levels. Now, will you give him immunosuppression?
Yes, sir. We will be giving
Because you have not
cyclophosphamide.
mentioned in your treatment that what you are giving.
Yes, sir. Actually, we are planning to give cyclophosphamide injection before discharging. So we will be giving cyclophosphamide to prevent further antibody production, at least for a period of around 3 months.
Okay. Sreejith, your comment, and then I think we have to, time is there.
Yeah, I think we have discussed most of the points, and I think we are running out of time. Can we ask Dr. Edwin to
Yeah. I think
talk about the treatment, sir?
Yeah. Can you stop your screen share, Sreejith?
Yes, sir.
Can you see my slides?
Yeah.
Yes.
Let's make it full screen. That's it.
Yes. So I'll just briefly touch upon the management according to some recent guidelines. I just want to tell you the epidemiology of anti-GBM disease from our part of the country. This is courtesy Dr. Anila Abraham's Center at Chennai. In a period of 9 years, the total native kidney biopsies were 41,000 odd, out of which crescentic GN was 3% of all biopsies. This crescentic means really more than 50% crescents. Anti-GBM disease, out of the crescentic GN, 248, that is 20% of crescentic GN was anti-GBM disease from this part of the country. So she just hurriedly gave me this data this morning.
That is significant. That
Yes,
20% of the
20%, yes. And she mentions that in the northern part of the country, PGI, the ANCA vasculitis seems to be more common than the anti-GBM. And in the southern part, the anti-GBM somehow seems to be higher. So this was one historical thing, bilateral nephrectomy for massive pulmonary hemorrhage and Goodpasture syndrome way back in 1973. And it was in 1975 when people spoke about cyclophosphamide, prednisolone, and plasma exchange. This is the Lockwood regime and Hammersmith Hospital protocol, where they just studied 7 patients who had with steroids, cyclophosphamide, or plasma exchange. And overall effect of immunosuppression and plasma exchange was the reduction in the antibody titers over the first 30 days. So this is again a paper, 1977, Goodpasture syndrome treated with immunosuppression and plasma exchange. So what would you do if there is an RPGN? Of course, I stressed upon the importance of urine examination. 40 dysmorphic RBCs, 5 acanthocytes, and 1 RBC cast. That would seal a diagnosis of proliferative glomerulonephritis. So the first point in the KDIGO 2021 is there should be no delay. Unfortunately, we are not able to address this because most patients do come in with significant delay, especially when they land up in tertiary centers like us. So when you have a RPGN, look at the CT scan, and if there's alveolar hemorrhage, then please look forward to send an anti-GBM antibody, ANCA, ANA, exclude infection. And as quickly as possible, if the logistics persist, allow you to have a kidney biopsy, including immunofluorescence within 24 hours. If there is no alveolar hemorrhage, and then we again look at the infections and the other investigations. And if the data is not back within 24 hours, the KDIGO recommends you treat with steroids and plasma exchange until the data are back, confirming a diagnosis. If the data are back within 24 hours, confirming anti-GBM disease, then you treat with steroids, plasma exchange, cyclophosphamide, monitor kidney function, pulmonary infiltrates, anti-GBM antibody titers, and the blood counts, and modify the treatment appropriately. So if there is no pulmonary hemorrhage, consider conservative approach in patients without alveolar hemorrhage, but who are oliguric or having advanced kidney failure requiring dialysis, especially if the high proportion of crescents on kidney biopsy. So this is again some historical data, 1996, looking at therapy of anti-GBM disease antibody. And antibody titers correlated with disease severity and relapse. So this is a graph showing the changes in the creatinine and the antibody to GBM concentrations in a patient. This is a paper in 2001. And what is the relationship between anti-GBM antibodies and kidney outcomes in patients with anti-GBM disease? So if you look at these graphs here, anti-GBM antibodies are closely related to kidney outcomes in patients with anti-GBM disease, and rapid reduction of antibody titer in the short term can be beneficial to improving kidney outcomes. So the other factor that is important, considering that determines the severity, is the avidity of the anti-GBM autoantibodies. That is associated. One of the earliest reports that avidity may be associated with disease severity. This is a risk stratification. This is a more recent paper. So there are some prediction tools that are be required to personalize care. The concept of the RRS is transferable to even anti-GBM disease. And it is important to stratify patients according to the need for renal replacement therapy at time of diagnosis, and the percentage of normal glomeruli in the kidney biopsy improves prediction further. So coming to the treatment, early diagnosis and treatment are key determinants to outcomes. Dialysis independence is uncommon in patients who require dialysis within 72 hours of presentation. Higher the initial creatinine, higher is the percent of glomeruli with crescents. If the creatinine is more than 5, there are likely to be more than 75% crescents and anti-GBM titers. And preferable to start empirical treatment before the diagnosis is confirmed to reduce the risk of developing irreversible renal damage. Whom to treat? Pulmonary hemorrhage independent of the presence and or severity of renal involvement. All patients with renal involvement who do not require immediate dialysis. These are the two populations. So the recommendation 1 is we recommend initiating immunosuppression with cyclophosphamide and steroids plus plasmapheresis in all patients with anti-GBM glomerulonephritis, except those who are treated with dialysis at presentation, have 100% crescents or more than 50% global glomerulosclerosis in an adequate sample, and who do not have pulmonary hemorrhage. This is only on 1C. So what are the factors that favor aggressive treatment? If there is pulmonary hemorrhage, yes. If oliguria is absent, if the creatinine is less than 5.5, if the ANCA is positive, less severe damage on biopsy, not a very high risk for immunosuppression, and other factors like creatinine more than 5 but recent and rapid progression. The crescents are cellular, recent, non-fibrous, and early transplantation is desired. Factors against aggressive treatment: if there is no pulmonary hemorrhage, if oliguria is present, if the creatinine is more than 5.5 to 6.5, if the ANCA is negative, the damage on renal biopsy is more severe, and the risk of immunosuppression is high. So we go by the Hippocratic principle, do no harm. Immunosuppression is of questionable benefit if there is a combination of dialysis requiring renal failure, no pulmonary hemorrhage, and 100% crescents. Consider a trial of immunosuppression in younger patients who are able to tolerate immunosuppression better. Very acute disease, irreversibility of the injury is less predictable, and if there are focal crescents with ATI. So what is the rationale of treatment? Plex removes antibodies, immunosuppression suppresses further antibody production. So this is a very old paper, 1985, where people treated anti-GBM disease with or without plasma exchange. 17 patients, 9 received immunosuppression alone, 8 received immunosuppression with Plex. The rate of disappearance of anti-GBM antibody is more rapid in the Plex group with better mean GFR at the end of therapy. And further analysis showed that the severity of renal damage on biopsy in entry serum creatinine correlated better with the outcome rather than the therapeutic modality. So these are the outcomes of different therapeutic regimes in a large single Chinese cohort, 221 patients. Plasma exchange with cyclophosphamide is superior. Plasma exchange, steroids and cytotoxic drug is superior. Formation of anti-GBM antibody spontaneously ceases in 6 to 9 months. So available data suggests that 3 months of daily oral cyclophosphamide steroids tapered over 6 months will prevent new antibody formation. Persistence of anti-GBM antibody, continued treatment with AZA or MMF with steroids. After 6 months, persisting anti-GBM antibody is rare. Of course, you would consider prophylaxis for pneumocystis with cotrimoxazole. And if there is a risk of serious infection, or if there is a serious infection, adding IVIG with antibiotics to be done, and IVIG to be given after the plasma exchange to limit its removal. Maintenance therapy. As we said, relapses are very uncommon. Relapse risk is increased in patients with continuous exposure to lung irritants or cigarette smoke. And no therapy is indicated for patients with undetectable anti-GBM antibodies after 6 months. So generally, a maintenance therapy is not required. What should we do for a double positive disease? 5% of AAB will have anti-GBM positivity. Up to 1/3 of anti-GBM disease may have ANCA positivity, may have severe renal failure and DAH. However, they have greater chance of renal recovery from dialysis dependence. Relapse risk similar to AAV and hence requires maintenance therapy as for AAV. So if there is an anti-GBM antibody with ANCA, then you have to consider maintenance therapy. This is a paper that looks at clinical features and outcome of patients with both ANCA and anti-GBM antibodies. Single center study. 5% of 954 ANCA had anti-GBM positivity, and 32% of 121 anti-GBM antibody had ANCA positivity. Of the dual positive, 82% were anti-NPO, as already mentioned by Gowri. And if you look at the outcome of double positive patients stratified by renal function at presentation in this paper, if you look at the 1 year renal survival, it is almost 0. So these are the treatment protocols. The plasma exchange, as rightly said, 40 to 50 ml per kg, ideally against 5% albumin. The maximum should not exceed 4 liters until the circulating anti-GBM antibodies can no longer be detected, usually 14 days. You have to add fresh frozen plasma at the end of plasma exchange in patients with alveolar bleed and or after kidney biopsy. Cyclophosphamide 2 to 3 milligram per kg oral. If the patient is over 55, consider reducing it to 2 mg per kg. This is oral cyclophosphamide. Experience with pulse is limited. In patients who are not tolerating or not responding to cyclophosphamide, Ritux or mycophenolate may be tried, but experience is limited and efficacy uncertain. However, cyclophosphamide is only for a period of 3 months. Steroids, pulse methylprednisolone, we give on the first 3 days, and 1 mg per kg orally reduced to 20 milligrams by 6 weeks and continue for 6 months. Very, very important during plasma exchange to monitor and correct the platelet count if it is more than platelet count. Aim for more than 70,000. Fibrinogen aim for more than 1 gram, may require cryoprecipitate supplementation. Hemoglobin aim for more than 9 grams. And corrected calcium aim to keep it in normal range. How to calculate the plasma volume? Often asked question in the exam. So this is the Kaplan-Hakim formula. You calculate the plasma volume calculation. And in somebody with plex, please anticipate a potential complication with FFP because 14% of citrate by volume is there in FFP. So this can cause metabolic alkalosis. And metabolism of the administered citrate generates bicarb, and excretion may be limited by kidney failure. And citrate-induced metabolic alkalosis can be corrected by HD if needed. So this is something to be kept in mind. Alternate options is rituximab in refractory anti-GBM disease. Very rare, less than 10%, limited experience. A favorable toxicity profile, of course, fertility sparing is very important. And this is a retrospective study of 8 patients treated with rituximab. And here in this particular study, anti-GBM patients, mean serum creatinine 3.2, received steroids with cyclophosphamide, and 5 also received plex. Relapse, 7 had relapse within 2 months. Rescue therapy with 4 weekly doses of rituximab. Complete remission in 7 out of 8 patients, mostly within 3 months of therapy. Mean follow-up of nearly 2 years, 100% patient survival, 75% renal survival, but Ritux did not improve the GFR, and anti-GBM antibodies remained negative for all. Only 1 patient had a severe bacterial infection. So the conclusion was Ritux may represent an additional and or alternative therapy in the induction treatment of anti-GBM disease. Mycophenolate, there are only case reports not recommended as a first-line therapy for patients intolerant having contraindications to conventional therapy. There are some papers showing the successful treatment of resistant anti-GBM disease with mycophenolate mofetil. Immune adsorption is the other modality that could be considered, especially with high affinity matrices binding selectively to IgG and IgM to remove circulating antibodies and immune complexes. Superior to plasma exchange in terms of efficiency of antibody removal and safety, and could be a cost-effective therapeutic modality, which could translate into a major clinical benefit. And this is one paper looking at the immunoadsorption treatment with a long-term outcome of anti-GBM disease. 10 patients treated with immunoadsorption. Anti-GBM antibodies became negative by 9 sessions. However, it was non-inferior to plex in elimination of anti-GBM antibodies, especially in patients with high percentage of crescents and dialysis dependency. This is again a paper published more recently, 2024. Immunoadsorption and plasma exchange are comparable in ANCA or anti-GBM removal kinetics. It shows that immunoadsorption and plasma exchange were comparable despite a faster reduction of the total IgG with immunoadsorption. The other drug that has been recently tried is imlifidase. We know that it's been used in antibody-mediated rejection. This is a IgG degrading endopeptidase from the Streptococcus pyogenes, cleaves the human IgG and inhibits antibody and complement-dependent cytotoxicity. This is the IgG degrading enzyme which has been studied, and the only thing that has been shown is it led to rapid clearance of the circulating and the kidney-bound anti-GBM antibodies. So 3 patients with dialysis requiring anti-GBM treated, rapid clearance. None of the patients regained dialysis independence. And this is another paper on the same subject. 15 patients with anti-GBM antibodies treated with imlifidase. 10 became dialysis dependent, while 10 patients had a GFR of more than 15. These are the reported cases of extracorporeal membrane oxygenation in anti-GBM disease. When there's severe pulmonary hemorrhage, probably you have to resort to ECMO. In severe lung hemorrhage, ECMO may be considered, appears to be associated with favorable outcome despite the requirement of systemic anticoagulation in the setting of alveolar bleed. Atypical anti-GBM disease, a word about it. It's slowly progressive. The nephrotic proteinuria, lung involvement is generally absent. It's more indolent course. The 1-year survival is quite good. The anti-GBM antibody may be negative. However, the biopsy may show different patterns: endocapillary, mesangial, MPGN, 50% polytypic and 50% monotypic. And this challenges the view that anti-GBM disease is a one-hit theory. Generally, we talk it as a tsunami-like phenomenon. So this is one atypical anti-GBM disease which is now challenging that particular thought. The difference here is, the antibodies, the antigen is also different here. It involves the alpha 1, 2, 4, 5, 6 chains. And though it is present in a very small group of patients, this has to be considered in patients who have got an indolent course. This is atypical anti-GBM disease from a French group, 25 patients, and you look at the multiple patterns of light microscopy pictures that could be seen. So generally it presents as endocapillary or mesangial proliferative GN pattern and appears to have a much slower disease progression. So other thing is, if you have a linear IgG, it is not always anti-GBM disease. There could be a diabetic kidney disease where there's faint linear IgG deposition along the GBM. MIDD, bright linear IgG deposition along the GBM and TBM. Punctate, powdery, Randall type electron dense deposits. And the other thing is fibrillary GN, where you could have a bright, smudgy linear IgG along with GBM. So it is not always anti-GBM disease with a linear IgG deposition. The other diseases like MIDD, fibrillary GN, and diabetic kidney disease also have to be considered. I would skip that and clinical. Okay, now we'll come to recurrent anti-GBM disease. So the key predisposing factors are smoking, hydrocarbon exposure, prodromal infections, comorbid autoimmune conditions. Notably, 50% of recurrence identified without identifiable triggers. And clinical presentations at recurrence, again, nearly 40% had lung and kidney involvement, 33% had only lung involvement, and 28% had only kidney involvement. So patients with concurrent systemic autoimmune diseases exhibited universally poor renal outcomes. What do you do for somebody who has persistent high anti-GBM antibody levels? The optimal management is not known, but treatment should be individualized. If somebody's got a 3 times high antibody titer, not decreasing in spite of daily plex and cyclo for 2 to 3 weeks, and evidence of disease activity like pulmonary hemorrhage, worsening kidney function, or persistent urinary sediments, probably you could try rituximab, 1 gram, 2 doses, 2 weeks apart, and extend the plex for about 4 weeks and reassess. If a patient has high anti-GBM antibody levels and is on dialysis, and the biopsy is suggestive of high percentage of crescents or glomerulosclerosis, IFTA, taper off the treatment and monitor the antibody levels. If there is persistent intermediate antibody titer after 3 to 4 months of cyclo-based therapy and recovered kidney function, switch to rituximab, 1 gram, 2 doses. If Ritux is not available, ASA 1 to 2 milligram per kg or MMF 1 gram BD, continue to for 6 to 9 months and monitor antibody level. These are suggestions by experts. There are no RCTs on this. A word about Crescentic GN in children. This is a paper from pediatric unit at AIIMS. So that is why I brought it here. A recent publication, 2025. So immune complex GN is the most common etiology of Crescentic GN in children. And anti-GBM disease was a very small, 5%. Some Indian data I wanted to share. Then recurrence and outcome of anti-GBM disease after kidney transplantation. As we know that the recurrence rate of anti-GBM disease after transplantation is low, but associated with graft loss, the long-term patient and the graft survival is excellent. This is a study of nearly 53 patients. Kidney transplantation in anti-GBM antibody, optimal timing of transplant at least 6 months of undetectable antibody levels. Again, the recurrence, whenever it happened in only one patient, and 5 years post-transplant in the context of cessation of immunosuppressive medications. And here, in this study, the patient survival was good. At 15 years, it was nearly 89%, and the death censored first-year graft survival at 15 years was nearly 79%. Outcomes after kidney transplant in anti-GBM disease, again, this is a large 13 French centers over a long period of time. Kidney transplantation in GBM glomerulonephritis offers comparable outcomes to control nephropathies. Here they compared to the other glomerulonephritis, and they did not find much difference. So let me sum up with some take-home points. Diagnosis should be quick without any delay. Treatment also has to be quick. Even before you get the report of the anti-GBM antibody disease, if there is a pulmonary hemorrhage, go ahead with Plex, steroids, and cyclophosphamide for selected patients. The duration of treatment, 3 months of cyclophosphamide, 6 months of steroids. Maintenance only for double positive patients. And refractory disease, do consider rituximab. So this Goodpasture syndrome and this anti-GBM antibody disease has got different phenotypes. The classic one, what you see here in green, the double positive anti-GBM phenotype, the double positive ANCA AAV phenotype, then the linear IgG on GBM circulating antibody preserved renal function, and then you have linear deposition and no circulating antibodies, variable glomerulonephritis without diffuse crescent. So different phenotypes of the disease we could see. So thank you very much for the patient listening. Thank you.
Edwin, wonderful. I enjoyed it. I think an excellent overview and updated data. Just before you people ask questions from you, a word about imlifidase. Any data?
Yeah. Yes, sir. Though we don't have access to the molecule right now. It brought down antibody levels fairly quickly. Whether it really translated to better outcomes in terms of renal survival or patient survival is not known, because we have very small numbers and very small number of studies on that.
I think that was
Even
very
in the
nice.
transplant setting, following treatment with imlifidase, the antibodies are supposed to return soon. So it seems to have a temporary effect.
Yeah, because that is a beauty, that if you can, for transplant, of course, if you can take it immediately after transplant. Yeah. I think we first have comments from the expert, Professor Kasi. Is Professor Kasi around? Yeah, please.
The presentation was quite crisp by Dr. Gowri. It was quite crisp. And you don't have to say about Edwin's presentation. It was excellent. A few points that came to my mind in general are that the urine examination is generally not, when the case is presented, urine examination comes last. I think it has to come first. All the other points that have been, important points have been discussed. We did not discuss the pathogenesis of anti-GBM and the genesis of anti-GBM and about the collagen and how the anti-GBM is created. But this program is not meant for the pathogenesis part. It is more for the clinical part. And I think it has been a very useful information that has been presented. The anemia of short duration. When a patient comes with a glomerulonephritis and a rapidly falling hemoglobin, one of the important things to be considered will be anti-GBM disease. Just wanted to include a few points about the pseudo pulmonary renal syndromes. We have discussed about the infections. We have talked about the leptospirosis, antivirus. The other infections are cytomegalovirus, even sepsis.
Yep.
Mycoplasma pneumonia is another cause. Then among the drugs, we mentioned about what is that we mentioned about the drugs?
Minocycline and
yeah, propylthiouracil. But then you have D-penicillamine, and even hydrolysine has been reported to have this complex involvement of the pulmonary. So these are some of the points that I just wanted to mention. Overall, it was very informative, and thank you, Edwin, for a nice review.
Thank you, sir. My pleasure.
Before I hand over to Professor Kher, I must thank Sri. Excellent case, very interesting. We had discussed in this forum ANCA, but we had not discussed anti-GBM. Thanks for bringing the case. And again, a rarity and uncommon thing that after 3 months, patient presents with alveolar hemorrhage. So keep in mind that if the anti-GBM antibodies are persisting, one can have problem anytime. And Edwin, wonderful discussion. And thank you, Gowri. Professor Kher, sir, for final comment.
Yeah, I think the questions predominantly, I think there are some questions on the chat as well. And I think one question is that 100% crescents is one hit sort of a disease, and that's why the crescents are usually uniform. But Edwin showed you that there may be some patients who may be atypical, and there is a possibility that there could be more than one hits, and sometimes recurrence or persistence of antigen. One doesn't know whether there is a persistent stimulation of the antibody through other methods as well. So typically, yes, one hit theory, and that's predominantly why recurrences are uncommon in this disease in comparison to, say, other diseases. Whereas this is important, and I think there's no doubt that Gowri and Sreejith and Edwin was remarkable, very succinct, very erudite, as well as fairly very comprehensive coverage. Coverage of good database as well, both old and young. And if there are young nephrologists who need to see how presentations must be made, and I think Edwin's presentation would be something that one would really appreciate and would like to envy and present the same manner. Not only the presentations, the slides were very clear and concise and didn't have too much of material on it. So excellent presentation, Edwin. No doubt about it. And Gowri did an excellent job in presenting the case as well as answering most of the questions. And so I think I would, are there any questions, further questions, General Verma?
No, I think
we covered most of the questions.
He has brought out atypical. Just incidentally, I had a patient recently, international patient. He came from one of the countries. I was not happy transplanting him because the kidney sizes were normal. I did not expect anti-GBM, but I biopsied him. I sent him to Dugal. I said, before I transplant him, and you tell me. And that is what he said. The crescents are at different stages. It was an anti-GBM disease, but crescents were at different stages. So that is how the response is always little better. So I told the agents who bring the patient that we will like to treat him. And before I said that, the patient disappeared. They took the patient away from me. So I mean, one has to keep in mind this atypical cases are.
No, even I had, this is about 20 years back, one patient who presented with some inhalation gas exposure and was in the respiratory ICU, and then they found that his kidney function was somewhat altered and they had some proteinuria as well. And they called me to see this patient, and I did a biopsy, and I was called by the pathologist. I didn't expect it that it would be anti-GBM because creatinine was somewhere around 1.8. He had some mild degree of proteinuria, and his urine output was good. He wasn't oligoanuric. So they called me, and this is linear deposits, and it must be an anti-GBM disease. We sent for anti-GBM. Anti-GBM was positive, but then he recovered his renal function significantly and continued to have these. So we treated him for a short period of time. The antibodies disappeared. He recovered almost to his normal renal function. So this was one of those atypical sort of anti-GBM disease, which was anti-GBM antibodies were also positive in this patient. And he had an exposure to some inhalation in one of the chemical factories. And that's where he was admitted predominantly with pulmonary symptoms, didn't have any hemorrhage, but he had an anti-GBM disease. So very mild presentation of anti-GBM disease. I have seen other two patients also over the last maybe 30 years, which were not typical anti-GBM disease, but atypical disease. So I think it does exist. These phenotypes are present. Most senior people would have seen one or two of such patients who don't always have that bad outcomes of these diseases that they usually. And we did transplant about 6-7 patients with anti-GBM disease, and fortunately didn't see any recurrence in any of these patients. So I think with this, I think probably if there are no other questions, I would like to thank both Sreejith, Gowri, and Edwin, along with Dr. Kasi for his usual.
One small comment, Dr. Vijay Kher.
Hey, there I see. There I see.
Nothing to do with today's subject. But in your discussion, we talked about.
Yes,
we talked about the senior citizen or an elderly person. Just for the information of everybody here, our panelists, Chief Dr. Kasi was made to retire at the age of 55 because the Kerala government thought his services are no longer helpful and required. So he retired at the age of 55. So that is just
young adulthood.
Young adult.
Yeah.
He retired as young adult, but he continues. He continues to work.
Yeah. What is lost for the Kerala government has been useful for the society and to the academic field.
Yes. He's still doing great. So thank you everybody, and maybe with this we thank from myself and General Verma. I would like to thank all the faculty as well as everyone who attended it today, and thank the Steadfast for giving us this opportunity as well as taking care of the logistics of doing this master class. In another 2 weeks we'll come with another master class, and thank you very much and goodbye. Good night.
Thank you so much, sir.
Good night, sir.
Bye-bye.
Thank you, sir. Thank you, faculty. Just to share with you, we crossed 100 again for this class and another 30 to 40 on YouTube. Thank you, everyone. Good night.
Thank you.
Edwin will